Dear colleagues, height disorders and skeletal maldevelopments, including achondroplasia, that reflects on appearance are well known long ago. From point of view of modern medicine, achondroplasia is congenital genetically conditioned disease. The main symptom of this disease is height delay, and at the end of natural growth, the difference is 35-40 centimeters. Expressed disproportions between body length and upper limbs is not only cosmetic disadvantage, but it also decreases functional abilities of the patient. At work, self-service, driving, causes compensative motions at shoulder girdle and trunk, which leads to secondary spine deformities. Lower limbs proportions restoration leads to patients' height increase for 20-30 centimeters, which increases disproportion between body length and upper limbs even more. It decreases the possibility for self-service and the possibility to increase the height of upper limbs. At the final stage of treatment, we perform humerus lengthening for anatomically and biomechanically based amounts. Our investigations proved that upper limb shortening is mostly due to proximal segment shortening. Expressed muscles significantly distort the anthropometric measurements, which complicates the definition of anatomical landmarks of bone. As a result of relative muscle excess, together with hand-height delay, arm looks shorter than other segments. Elbow joint contracture at some patients can be 110 degrees, puts serious distortion at projective bones length. That is why true correlation of proportions of segments of upper limbs in achondroplastic patients better to determine by lateral view of X-ray. To restore correct biomechanical chain of upper limb, we should perform proximal osteotomy above tuberosity deltoides and distal one at supracondylar area. At the length of distal regenerate should be 30% from total amount of lengthening. It allows to restore biomechanical proportions between muscles length and humerus. The process of humerus lengthening is accompanied by changing of segment volume. In case of average amount of lengthening 67%, its volume increases for 60%, and correlation between shoulder volume to its length comprised 16 cubic centimeters at 1 centimeter of humerus length, which is 96% from initial level. It confirms that all tissues of shoulder are actively growing, not only stretching. There were no signs of skin stretching at lower third of shoulder. According to X-ray with dye and sonography, after lengthening, muscles shape, length, direction and structure of muscle fiber and intramuscular septa have structure similar to normal. Radiologic criteria for regenerate maturity by the time of frame removal was uniformity of structure, formed cortex layer as linear structure of bone density. Ultrasound criteria of regenerate maturity is formed cortex layer as uniformity linear, hypoechogenic signal, and echonegative In long-term follow-up, after frame removal, Bone structure obtains normal view and uniformity of medulla canal is fully restored. The example for that is 3D relief of optical image of X-rays. X-rays processing algorithm demonstrates obvious decrease of optical density of regenerate if to compare with the maternity bone. X-ray processing algorithm is that the resulting image embossed surface height and color of each point is a function of brightness, that is, density of the original image at this point. Clinical example: 13-year-old patient diagnosed with achondroplasia, low height, tibial lengthening for 14 centimeters. At the final stage of treatment, we performed double corticotomy of both humeri, Ilizarov fixation, 77 days of distraction and 82 days of fixation. 10 centimeters achieved lengthening. Flexion contracture of elbow joints were eliminated. Treatment result was good. Complications after lengthening: 808 patients and 216 segments. Most common complication is pin track infection, which comprised 12% from total amount of lengthened segments. Only in case of not effective conservative treatment, we had to pull out the wire. Main reason for this complication is that wires cut in soft tissues during distraction. Neuropathy, 18 cases developed in early post-operative treatment, and it was caused by nerve trunk contusion at complete fracture of cortex. Clinically, apparent violations in the form of radiating along the nerve damage pain arising from the movement of the elbow, sensory disturbances at the back of the forearm and hand. Decrease of absence or active function of hand and fingers extension with thumb abduction accompanied with couple gripper force was observed in 2% of cases. Considering the level of damage, lower third of segment, we decreased distraction rate for all patients up to 0.75 millimeters per day. Conservative treatment was conducted as well. In spite of the fact that lengthening was carried on, there was regress of neurologic symptoms accompanied with bioelectrical activity of muscles, which proved efficiency of chosen tactic. So, this complication is not a contraindication for further distraction of the limb. All patients achieved humerus length as it was planned initially, hand function restoration by the end of fixation or during 1 to 2 months after discharge from the hospital. Absence of diastasis between the bone fragments at osteotomy site after distraction means incomplete osteotomy. Total amount of such mistakes, 4% from amount of lengthened segments. 7 of them were a distal fragment. In 3 cases out of 8, lengthening was performed at proximal level. In 3 cases, 5-7 days after distraction, was acute rupture of bone fragments under distractional forces. 6.3% of cases with angular deformities were as a result of unstable osteogenesis. Reasons of instability can be wire breakage or loosening of the wires, tension decrease, wire removal in case of pin track infection. In bifocal osteosynthesis, in most of the cases, deformities occur at the level of proximal osteotomy, varus or varus anticovatum. The possibility of deformities is higher in case of monofocal osteosynthesis. We believe that the reason is longer bone fragments which increase force applications levers, and it demands stronger fixation to the stability of osteosynthesis. Deformities after frame removal were observed in 5 cases and were as a result of not following the doctor's recommendation. One patient had humerus fracture at regenerate site because he fell at arm 6 months after lengthening. Repeated osteosynthesis was done for 2 patients with deformities. As you can see from the table, presence of complications increases treatment duration in monofocal and less in bifocal destruction osteosynthesis. In 8 patients, presence of complications did not affect duration of treatment. Difference in hand length was observed in 1 case. In all other cases, deformities obtained during treatment were not eliminated completely and they did not affect function. In other cases, complications were diagnosed in time and they did not influence on treatment result, although treatment duration increased for these 8 patients. Ilizarov method provides all necessary conditions for complications prevention. And they provide complications prevention. Stable osteosynthesis, low trauma at surgical interference, full blood supply, optimal distraction rate, possibility of weight bearing on operated limb during treatment. Bifocal distraction osteosynthesis shortened terms of osteosynthesis and number of complications in comparison with monofocal osteosynthesis. Thank you for your attention.
Thank you very much for your kind lecture and very impressive results. And time is now open for the discussion. We shall discuss to the first lecture of